which I'm going to talk about today, will emphasize the downside of some of the care which we provide for our patients. But that's not to minimize the important role which imaging plays in the care which we provide to our patients. Certainly, imaging offers improved diagnosis, prognostication, the ability to affect medical therapy, guidance of interventions, and ultimately, what's most important is how it can play a role in improving patient and societal outcomes. So while we're going to focus on the downside, these are important to keep in mind. Nevertheless, at the same time, there is a potential danger from imaging, and that's something which is very important to consider. This was recognized by no less a figure than the illustrious physician and rabbi after whom your medical center is named, כתב הרמב"ם, הואיל והיות הגוף בריא ושלם מדרכי השם הוא, שהרי אי אפשר שיבין או ידע דבר מידיעות הבורא והוא חולה, לפיכך צריך אדם להרחיק עצמו מדברים המעבדים את הגוף. Even Rambam recognizes that there are things which are damaging, and it's incumbent upon us. In fact, to Rambam, it's a religious obligation to avoid such things. I would contend that radiation is one such matter. In the course of the next half an hour or so, what I'd like to talk about is why we should care about radiation dose, some terminology which is used in characterizing radiation, talk about how radiation dose is estimated in practice, and then go on to taxonomize a bit doses to patients of common radiologic and cardiac procedures which your patients may be receiving, talk about the problem of multiple testing, and then move on from radiation dose to cancer risk. How do we estimate cancer risk to our patients? What's a little bit of the evidence base behind it, and ultimately, what principles can we use in reducing dose and risk to our patients? So let's get started talking about why care about radiation dose. In the United States, over the past decade or decade and a half, we've seen a remarkable growth in the utilization of medical imaging. Here's one procedure, for example, myocardial perfusion imaging, which has increased about 2.5-fold over the course of a decade before leveling off a bit. Computed tomography, the growth has been even more remarkable, an increase of 3-fold over the course of a decade. Together, this increase in radiation dose and perhaps the increase in dose from individual procedures has led to what's been perceived as a public health problem. If you take a look at the pie on the left, it reflects the total radiation burden to the United States population in the early 1980s. And from the same organization, the National Council on Radiation Protection, the radiation burden by the mid-2000s. While background radiation hadn't changed, medical radiation increased 6-fold. Much of that is due to CT. However, nuclear medicine and nuclear cardiology is an important part of that pie as well. Lest you think that this is just an American problem, we've also seen a lot of growth in imaging in Israel. And while there's not as much data, what is known is that approximately 850,000 CT examinations are performed per year in a population of perhaps 7 million. There are 30,000 interventional procedures performed per year and 13,000 new radiotherapy patients each year. The growth of CT in Israel, this curve mimics that seen in the American population. We've seen basically a doubling of the use of CT per capita in the Israeli population over the course of the 1990s and 2000s. Interventional procedures, I was here 2 days ago for your outstanding interventional meeting, and while there have been great advances from cardiac catheterization, we're seeing more patients receiving cardiac catheterization. Concomitant with that is a radiation burden, and that's one aspect of this about which we need to be concerned. There's been some work relating a country's annual X-ray and CT frequency to the attributable risk of cancer. And as you can see, there's a roughly linear relation. The more X-ray involving procedures which are performed in a country, the higher the attributable risk of cancer. Where does Israel fall in this? Well, somewhere in the middle, based on worldwide data. In terms of the number of CT scans, there are many developed countries which Israel performs more CT scans than. Why don't we move on and talk about a little bit of the terminology which is used in characterizing radiation dose. Ultimately, international standards classify radiation's effects into two. Deterministic effects, which are basically those due to radiation-induced cell death, and stochastic, which means probabilistic effects, which are due to mutations. A little bit more, deterministic effects only occur above a threshold dose, which is typically high, may vary from individual to individual, but it will only occur after generally a large proportion of cells in a tissue have been killed by radiation. The severity of these effects may increase with dose. A typical kind of deterministic effect is skin changes or hair changes. You can see an extreme case here where a patient had a painful, non-healing transdermal ulceration, all due to radiation from an interventional fluoroscopy procedure. In contrast, we have stochastic effects, which are due to mutations. The severity of stochastic effects don't depend on the dose, and the most common types of stochastic effects thought to occur are neoplasms, that is cancers, which occur after a latency period. For solid tumors, that's about 5 to 10 years, and for leukemia, it's about 2 years. Another type of stochastic effects is hereditary effects, but these occur much less frequently than neoplasms. In imaging, the typical effects which are observed are stochastic, and a common assumption is that risk is proportional to dose at low doses. How can we quantify ionizing radiation? There's basically two types of measures of the effects of ionizing radiation. One is dose, which is a measure of energy deposition, and the other is risk, which is the probability of an untoward event, such as cancer occurring due to that radiation. There's a bevy of terms used to describe the type of radiation doses. The simplest type is organ dose, which just measures the average deposition of energy in joules per unit mass in kilograms. A special unit for that for an organ is called the milligray. What's used more commonly in the medical literature nowadays is something called effective dose. Effective dose is a doubly weighted measure of the amount of energy deposited per unit mass that is weighted both to reflect the type of energy and weighted to reflect the relative radiosensitivity of each organ. Some organs are more predisposed to developing cancer from being exposed to ionizing radiation. When we sum up these doubly weighted organ doses, we get what's called the effective dose, and the special unit to describe effective dose is millisieverts. So often you'll see millisieverts, or MSV, in the literature. In practice, it's difficult to determine the effective dose associated with a particular examination. We can't measure energy deposition in organs directly. So what we typically do is use special modality-specific measures from which, in many cases, effective dose is estimated. Examples of such are the dose length product in computed tomography and the Kerma area product in fluoroscopy. How are these determined? Typically, they're measured using phantoms. You can see this 32-centimeter plexiglass phantom in which an ionization chamber is placed. This enables us to measure ionization events occurring when X-rays are delivered not to a patient but to this phantom. And this is reported by our CT scanner. What we can do is determine something called the dose length product, which is reported on our CT scanner, and then multiply that by a conversion factor, standard values of which are given by European guidelines to estimate an effective dose from a particular procedure. So what are effective doses of our procedures? Let's start actually by talking about some non-medical radiation exposures, and then we can compare medical radiation exposures. What's often used as a benchmark is a standard PA chest X-ray, postero-anterior chest X-ray, which has an effective dose of about 0.02 millisieverts. My round trip between New York and here will probably result in my being exposed to an effective dose of about 1/10 of a millisievert, or 5 chest x-rays. Backscatter scanner for airport screening is associated with a dose of about 0.001 millisieverts, or 1/20 of a chest x-ray. Worldwide, according to the United Nations, the annual average background radiation is about 2.4 millisieverts. And the highest doses received by radiation workers in Japan in the recent tragedy is about 100 times that. So how about the procedures which some of your patients may be receiving? A PA and lateral chest x-ray is associated with considerably more radiation than just a PA chest x-ray, about 5 times more, but the dose is still relatively low. You can see here some of the other types of x-rays which your patients might receive. A lumbar spine x-ray is associated with considerably more radiation, or a thoracic spine x-ray. Those are equivalent to about 50 chest x-rays. Abdominal and pelvic x-rays also are associated with about 30 times more radiation, and orthopedic x-rays in general are associated with very low doses. You can see a shoulder or a knee x-ray is associated with an effective dose of about 1/100th of a millisievert. If we have gastroenterologists in the crowd, some of the procedures which your patients undergo are associated with considerably higher doses than a standard chest x-ray, typically on the order of 5 to 10 millisieverts. Dental x-ray really depends on the type of procedure. The typical dental x-rays which we all get when we go to our dentist's office are associated with very low doses, about 1/100th of a millisievert. A Panorex is associated with about twice that. But dental CT, which in the United States we've seen proliferating in the past few years, is associated with considerably higher doses. What's of note is that cone beam CT has an effective dose about 10 times that of a Panorex, but fan beam CT, a more conventional technology, is associated with a dose 100 times that. So really, for our dental patients who need CT, cone beam is the way to go. In terms of CT procedures, head CTs are generally associated with lower doses than other types of CTs. An exception to this is when CT perfusion of the head is performed. For example, in our emergency department patients who present for ruling out a stroke and have perfusion procedures. But in general, head CTs are associated with lower doses than other CTs. Nuclear medicine procedures, the doses vary as well. Thyroid scan, it depends on the isotope. Ventilation perfusion scan is associated with a relatively low effective dose in comparison to a CT pulmonary angiogram. You can see some other procedures here as well. I'm a cardiologist and very concerned about radiation safety in cardiology. And there's really a variety of procedures which our cardiac patients undergo from which they're exposed to ionizing radiation. A cardiac cath typically is associated with a radiation dose of about 7 millisieverts. CT angiography is interesting because a variety of doses can be observed depending on what type of cardiac CT procedure is performed. Conventionally, we had performed helical CT, in which the X-ray beam is left on continuously. There are methods used which drop the X-ray tube as a function of where we are in the cardiac cycle, and that can drop dose by about 1/3. But most recently, in the past 3 or 4 years, we've seen many centers introduce scanning using prospective triggered gating. In this method, the X-ray beam is left on only during a short period, typically during diastasis, and turned off during the rest of the cardiac cycle. By virtue of using this method, we can drop doses considerably, typically by about 80%. Cardiac SPECT procedures depends on the procedure. The most common procedure used worldwide is a low-dose rest, high-dose stress or vice versa, a technetium-99-based procedure, that's associated with an effective dose of about 10 millisieverts. Although dual isotope scanning using both thallium and technetium-99m is quite widely used, and that's associated with one of the highest doses of any medical imaging procedure, about 25 millisieverts. PET procedures are associated with considerably lower doses, in large part due to the short half-lives of the radiopharmaceuticals used. Many of our patients don't receive just a single procedure, but they receive multiple procedures. There have been a number of studies in the past couple of years about that. I'd like to briefly cover three of them. One study which looked at all sources of radiation in a large insurance cohort, one looking at CT alone in one institution, and one looking at myocardial perfusion imaging at my own institution. So the first study looked at claims data from United Healthcare, a large payer in the United States, in 5 different markets. We looked at all enrollees who were adults but non-elderly, who were continuously enrolled for a 3-year period, and doses were estimated for typical doses from procedures. In this study, we considered nearly 1 million patients of average age about 35, comprising nearly 3.5 million imaging procedures. The average patient who was enrolled in this insurance cohort underwent about 1.2 procedures per year. And procedures involving ionizing radiation were performed in over 2/3 of the patients. What did we find? The average annual effective dose from radiation in these patients from medical radiation was 2.4 millisieverts. You can see that these mean doses in this column. There was a slight difference between men and women. Women were exposed to more radiation than men. And as patients got older, they were exposed to more ionizing radiation. Interestingly as well, there were differences between the different healthcare markets. There are regional variations in the utilization of medical imaging and consequently in the amount of radiation which patients received. In terms of the annual effective doses, most patients received no or low doses of radiation. However, about 20% of patients had moderate annual effective doses, which were more than the radiation which these patients were exposed to from background. About 2% of patients had what was classified as high doses or very high doses of radiation, and these individuals underwent received more radiation than the occupational limits for radiation workers. Which procedures accounted for the most of this? Well, myocardial perfusion imaging and CT really topped the list. About 22% of radiation dose in this cohort came from myocardial perfusion imaging, and then CT of the abdomen, pelvis, and chest followed shortly thereafter. What lessons did we learn? Well, most people get some imaging involving ionizing radiation, but high and very high doses are less common. Nevertheless, in the American population, that would translate to 4 million non-elderly people receiving these high or very high doses. There are differences between regions, and as I said, differences between men and women. Another study looked at cumulative radiation dose from computed tomography. This study looked at all patients undergoing CT at the Brigham and Women's Hospital in 2007, and they identified all diagnostic CTs performed in a 20-year period, ending the year after that. They estimated effective doses, and this involved 31,000 patients. What did they find? Well, you can see a highly skewed distribution, and this is really characteristic of all cumulative radiation dose studies. The typical patient undergoing CT received three CT scans. That is the median number of procedures in this cohort of patients exposed to CT in 2007 was 3. The mean was 6, but you can see this large tail, and 1% of patients received 38 CT scans or more. What did that translate to in terms of cumulative dose? The median cumulative dose was 24 millisieverts. The mean was over 50, but 1% of patients received cumulative doses of over 400 millisieverts, which is nearly 10 times the annual limit for radiation workers. We see there are high rates of recurrent CT imaging, but a skewed distribution. Lest you think that this is just an American problem, here's data from Israel on the number of CT tests performed per patient in Israel among individuals who receive CT scans. Over half of individuals receiving CT scans in Israel receive multiple CT scans. And over 10% of patients receiving CT scans in Israel receive 5 CT scans or more. One final study on cumulative dose is some work my colleagues and I have done on cumulative radiation dose in myocardial perfusion imaging patients. We looked at over 1,000 patients from our institution and identified all the procedures that these patients received over a 20-year period. The typical patient undergoing myocardial perfusion imaging over that 20-year period received an average of 24 procedures involving ionizing radiation. But of the high-dose procedures, that is, the CT procedures, myocardial perfusion imaging procedures, and fluoroscopic procedures, that was only 6.5 procedures per patient. And most of that was from myocardial perfusion imaging and CT, for which there was a mean of 2 and 4 procedures respectively. In terms of radiation dose, what did that translate into? Well, the mean dose from all radiologic and cardiac procedures in these patients was nearly 100 millisieverts. Over 30% of patients received doses of over 100 millisieverts, and over 10% of patients received doses of over 200 millisieverts. Women underwent more procedures than men, which was significant even if mammography was excluded. However, men had higher cumulative doses. Interesting, there were differences between ethnic groups. Multiple testing was certainly a problem. Over 30% of patients underwent multiple myocardial perfusion imaging exams. The median time interval between repeat myocardial perfusion imaging studies was 24 months. But over a quarter of patients had multiple nuclear stress tests within a 1-year period. And these patients who had multiple tests had very high cumulative doses. So overall, what do we learn from these studies? Well, the population burden from medical radiation is not at all evenly distributed. Rather, distributions are skewed, and there's a small subset of the population who receives a much higher dose of radiation. Moreover, there are gender, racial, and regional differences in radiation burden. And we need to focus more on these patients receiving very high doses of radiation. Now, what does radiation dose have to do with cancer risk? We don't have time in this session to discuss all the epidemiologic data, but I would like to point out how difficult it is to conduct such epidemiologic studies. Why? There's a very high background rate of cancer in the population, so if we want to detect a weak signal above that, we need very large cohorts. This figure illustrates the size of a cohort that would be exposed to different radiation doses, which would be required to detect a significant increase in cancer mortality. As we saw, CT procedures are commonly associated with radiation doses between, say, 10 and 20 millisieverts. So that would require hundreds of thousands of patients in an epidemiological study. As of now, we just don't have such studies. The 3 closest studies which we have of ionizing radiation at these low doses come from atomic bomb survivors in Hiroshima and Nagasaki, from radiation workers, and from in utero X-ray exposure. All of these 3 studies showed a statistically significant excess risk of cancer from radiation. So we think that radiation is associated, these doses of radiation are associated with an increased cancer risk. Nevertheless, it would be nice to have better epidemiologic studies which involve patients undergoing medical radiation. In fact, a number of such studies are underway, the largest of which are in Ontario in the United Kingdom, and we should have data as early as this year available. One of these studies is being conducted in Israel through Maccabi. They're looking at patients both at Schneider's Children's Hospital as well as in Maccabi. And in total, this is looking at about over 60,000 individuals in Israel who received 60,000 CT scans performed in Israel. They're in the midst of this study, and we look forward to the results of that in the years ahead. So how do we estimate cancer risks to our patients from radiological procedures? Because we don't have actual epidemiologic data on these patients, what we need to do is extrapolate from the existing epidemiologic data. The framework for doing this, which is commonly used, is the US National Academy's BEER 7 report. BEER is Rashi Tevot for Biological Effects of Ionizing Radiation, and this report was published in 2006. Number one, it reviewed the available data and looked at various models of cancer risk. It supported this linear no-threshold risk model. What does that mean? It means that the risk of cancer proceeds with radiation dose in a linear fashion, meaning increased dose, increased cancer risk, and as well as the fact that there's no lower threshold, meaning even the smallest amount of radiation has, albeit a very low risk, a risk of cancer. In addition, this BEER 7 report developed the most up-to-date risk estimates for cancer from exposure to low-level ionizing radiation based on a comprehensive review and synthesis of the world literature. And these models relate organ doses to organ-specific cancer risks. So how do we know what the organ doses our patients receive are? We can't put dosimeters into our patients, but we do have both computational and physical phantoms, which we can use to measure radiation dose. So by simulating a scan using some sort of phantom, determining what the organ dose is, and then using the epidemiologic methods developed in the biological effects of ionizing radiation report, we can estimate cancer risks. This has been done in a variety of contexts. My colleagues at Columbia estimated this in pediatric CT. My colleagues and I looked at cancer risk from coronary CTA and found cancer risks to vary dramatically depending on patients' age, gender, and the scan protocol utilized. And it's also been utilized for myocardial perfusion imaging. Nevertheless, there are a number of limitations to this cancer risk estimation approach. It's not using actual epidemiologic data from these patients who are exposed to scans, but rather extrapolating from other populations. And specifically, it's extrapolating much of this data from a Japanese population, which has different baseline cancer risks. There are a number of other assumptions, including this linear non-threshold relationship between radiation dose and cancer risk. So while these are the best tools which we have at our disposal now, there certainly is considerable uncertainty. I'd like to close with a few principles of radiological protection. The international system really recommends three general principles. Justification, we need to justify every test that it's necessary. Optimization, we need to optimize the amount of radiation received by patients from each of the radiologic examinations. And number three, diagnostic reference limits. That is, we need to know what amounts of radiation are simply too much, or specifically, how is justification defined? Here, the commission, that is the International Commission on Radiological Protection, recommends that when activities involving an increased or decreased level of radiation exposure are being considered, the expected change in radiation detriment should be explicitly included in the decision-making process. We need to justify our tests and need to consider radiation as we're making our decisions as to what tests our patients should undergo. In practice, how can we evaluate justification? Or how can we justify procedures? In the United States, a number of professional societies have gotten together to develop what are called appropriateness or appropriate use criteria. Here's an example of one such consensus report, and that's that's for cardiac CT. As you can see here, the negative consequences which need to be considered include the risks of the procedure, such as radiation. Using these tools, we can assess the appropriateness of the procedures performed. Here's one recent study from the Mayo Clinic, really one of the most outstanding hospitals in the United States. Only about half of patients were classifiable, but if you look at the right side of the pie chart here, only half of the classifiable cases were considered appropriate. Using these standardized criteria, as many patients were inappropriate or uncertainly appropriate as were those who had appropriate procedures. So by developing such tools, we can benchmark where we are and try to improve upon it. I'm happy to observe that in Israel, you've begun a process of developing appropriateness criteria, and here's the comparable document in Israel for appropriate use of cardiac CT. I hope you'll develop more such documents in the future in other areas where ionizing radiation is applied. The second major radiological principle is optimization. This is defined by the International Commission as the source-related process to keep the likelihood of incurring exposures and the magnitude of individual doses as low as reasonably achievable. That's the ALARA principle, as low as reasonably achievable. If we've committed to performing a patient on our patients, we should still keep the amount of radiation as low as reasonably achievable. How can we implement this for the various modalities which we use? Let's talk about it for CT, nuclear medicine, and fluoroscopy. In CT, we can match the tube voltage and current to the diagnostic task at hand and the patient's size. In some applications, lower kilovoltage or lower tube voltage will increase contrast and decrease radiation dose to patients. And in many cases, we can modulate tube current either by means of synchronization with the electrocardiogram or by means of anatomic tube current modulation. We can minimize the scan length. If I have a particular clinical question to answer, it doesn't mean that I need to perform a standard CT of the abdomen and pelvis if I'm only interested in one organ within the abdomen and pelvis. We can utilize new technological advances to reduce dose. New iterative reconstruction methods have become popularized and introduced by each of the vendors in the past year, and these will enable us to reduce dose. And as we saw in cardiac CT, there are novel scan modes which can reduce dose. In cardiac CT, there are unique challenges, and simply using beta blockers to aggressively lower patients' heart rates will reduce the amount of radiation which they receive. As you can see in this figure, if you look at the curves on the top, which are colored, these are estimates of cancer risks from cardiac CT using standard technique. If we utilize this prospectively triggered methodology, we get cancer risks using the bottom curve. So decrease in dose, at least using the methodology of the BEER-7 report, can translate to reduced cancer risk to our patients. In nuclear medicine, we should minimize the activity needed that's necessary for good image quality with a high degree of confidence. And in smaller patients, we should give less radioisotope. We need to know the dosimetry of competing radiopharmaceuticals. For example, in cardiology, thallium is associated with higher radiation doses than technetium-99m. If we can hydrate patients and decrease dose to the kidney and bladder, we should consider the necessity of each dose in studies which involve multiple doses to patients, and we can use technological advances to reduce dose, such as solid-state cameras, which are being developed by a couple of companies in the Haifa area, in fact, and improved image reconstruction algorithms. For fluoroscopy, as we spoke about on Tuesday, we can minimize fluoroscopy and fluorography time. We consider retrospective acquisition of fluoro as an alternative to cine. We can employ the slowest fluoro and cine frame rates that maintain image quality, keep the table high, and minimize the distance from the patient to the image detector. Often using an LAO approach rather than an RAO approach will decrease radiation dose. And we can consider shielding sensitive organs. These general principles of justification and optimization have really been adopted by governmental agencies as well. You can see here a recent statement from the United States Food and Drug Administration in their initiative to reduce unnecessary radiation exposure. FDA is advocating the adoption of these principles: appropriate justification of the procedure and optimization of the radiation dose. What approach does the Misrad HaBriut have to this? There are really 5 principles which they're emphasizing: justification, optimization, quality control, training, and keeping a record of radiation exposure, which is something I think you'll be hearing more about in Israel. They're focusing on high radiation dose examinations, such as CT, nuclear medicine, and interventional procedures. They're paying special attention to populations at risk, such as children and pregnant women. And there are national projects in terms of mammography and radiotherapy. I think at this point, I'll stop and open the floor for some questions. Thank you for your interest.